Assalamu alaikum. Good morning. My name is Dr. Mohammad Mashkur Aslam, resident of Urology at SIUT. Today we will be discussing the genitourinary cancer management, especially in this severe pandemic, and how we can utilize rapid communication tools, for example Twitter, for evidence-based guidelines and to change some guideline practices. So our learning objectives include COVID-19 pandemic, how this has changed our clinical practices, and what are the rapid communication tools, especially Twitter, which we can utilize in order to change the practice and modify our previous clinical skills, and communication with international urologists in order to know what are the changing practices they are practicing in their countries, and then the evidence for the safety of delayed surgery. And this evidence will be included for prostate cancer, kidney cancer, bladder cancer, upper tract urothelial cancer, and testicular cancer. Then finally take home a message and also summarize this whole case. So COVID-19 pandemic, initial case was reported in December in 2019 in Wuhan, China. And it was declared pandemic within 10 weeks, and then in April 2020 there were 2,400,000 cases and 165,000 deaths. Most effective tool, there was no treatment, there was no vaccine available, so we have got only one option, that was social distancing. So when we observe the social distancing, this means we have to cancel all the non-urgent or non-emergent medical care cases in most parts of the world. So another question arises that what is considered essential and what is necessary. This we will be discussing in upcoming slides. What is important is that earlier guidelines which came for regarding COVID-19, they became outdated within days. For example, SAGES and EAES, they were required an update within 8 days due to changing in the pattern and not knowing how this COVID-19 acts. These are the estimated cases in March 2020. First one is the Italy. It was hit hardest. It has got 35,000 cases. Then comes the Spain. It has got 13,000. Then South Korea, United States, United Kingdom, Australia, and Brazil. Then how rapid communication via Twitter. The rapid communication mean that we can communicate with each other within seconds or within minutes, and we can communicate with the whole globe. So Twitter is an excellent app which can provide this opportunity. The question was that how to outweigh the risk. What is the benefit of doing surgery in this scenario, and what are the benefits of delaying? So we have to risk the COVID-19 exposure versus the risk of deferred treatment. If we defer the treatment, then we can have a worse prognosis and worse outcome in our patients. But if we proceed with the surgery, then we will have the more patients and doctors and staff will be exposed to COVID-19. This image shown in this slide, it shows that the Twitter is an excellent app, and it has got 70,000 impression in only 6 days. So it was a very active participants, and a lot of discussions took place in this period in order to make these guidelines, which we will be discussing in upcoming slides. Then comes the change in the pattern. In this slide, change in the practice pattern, we will be discussing about prostate cancer management, for example. So there were approximately more than 150 responses and more than 24 specialists from different parts of the world, including USA, Europe, and Australia. Almost all of them agreed for the intermediate risk prostate cancer that they can be safely deferred for more than 6 months, and we can also use ADT while waiting. ADT means androgen deprivation therapy. Then comes the high-risk prostate cancer. There are various groups, some from the USA, then the USA, UK, Australia, and some from the USA. Some of them, they advise that we can use ADT for safer postponement of the surgery. And some of those who were in the decision of the postponement, they also said there is no strong evidence of benefit and ADT has got some side effects. However, on the other side, so few of them said that no evidence of harm is also noted, and ADT is standard of care with XRT, means radiotherapy. So there is if we have no therapy for more than 6 months, then adverse outcomes will be observed. On the other hand, some of these clinicians, they propose that all cases should be postponed, and we have to preserve personal protective equipments and resources. And they said that the untested COVID-19 patients, they have increased COVID-19 risk to providers and patients. And some of the USA clinicians also said that there are concerns over litigation and COVID-19 testing kits were short. Then some other clinicians, they said that we can proceed with the primary treatment. These primary treatments include surgery as well as radiation. The surgery has some benefits. These are the short stay, limited exposure to staff, and limited resources utilization, as the patient will be admitted for a short period of time and will be discharged as soon as he gets stable. And COVID-19 testing can help. So in this scenario, we can proceed with the surgery after testing all the patients for COVID-19. And on the other hand, radiation, some were suggesting that radiation is a better choice, but they have to visit 35 to 40 times, and this will increase the exposure, and this is also waste of resources. So some of the radiation experts, they also suggested another option, which was hypofractionation, that can be used, but still they have to visit a lot of time in order to get hypofractionation. Then lastly, the use of existing capacity, we have to save some capacity before the pandemic bursts, and pandemic is open-ended. We don't know how it will end and when it will end. Then the communication with the international urologist. They also communicated with different parts of the globe in order to know what are the changing practices they are observing. For example, in South Korea, which was the second most infected case, second most infected state after China, they had minimal interruptions of the elective surgery in the beginning. Then the Brazil, all elective surgeries were postponed. Italy, which was hit hardest, they turned their major hospitals into COVID-19 centers, and 30% of their urologists were deployed to the COVID-19 patients as well. All the international conferences, major international conferences rather, including annual EAU and AUA, they were cancelled, and they called a virtual meeting in order to proceed. Then comes the evidence for the safety of delayed surgery. So fortunately, within the realm of the urologic oncology, we have got heterogeneity, and different tumors behave differently. So there is a considerable flexibility, and we can use that flexibility in order to schedule the surgery. And this existing evidence, which was peer-reviewed literature for risk stratification, and they also decided for the deferred surgical management, and use that evidence-based guidelines in order to judge that how safer they could be when we defer the surgery. So starting from the prostate cancer. Prostate cancer, first of all, is the low-risk disease patients. In these patients, there is strongly considered for AS protocol, that is active surveillance protocol. One of the studies that took place at Toronto, they suggested that their outcome suggested that 10-year and 15-year metastasis-free survival rate were 96% and 95% respectively. And another study at Johns Hopkins which suggested, their results suggested that metastasis-free survival rate was exceeding even more than 99% at 10-year and 15-year follow-up. However, what is important in this scenario is that the patient should not be counseled in this way that the surgery can be delayed safely. However, they should be told that no intervention is required, no intervention is necessary. And if surgery is delayed, then other non-surgical therapies, for example, focal ablation and radiotherapy, they should also be discouraged. And what we will be doing while waiting for this active surveillance, we can use adjuvant tools, for example, MRI, in order to reduce the number of biopsies and know the disease progress. Then the intermediate risk disease. The patient with the grade group 2 prostate cancer, with the, for example, lesion score 3 plus 4 is equal to 7, they were placed in the active surveillance group. Those who were placed in an active surveillance group, their metastasis at the 15-year were found to be increased by nearly 4-fold. However, in this study, the active surveillance protocol were not very stringent. For example, there were long biopsy intervals and they did not differ among men with a GG1 and GG2 cancer. So what we can do is that in younger patients with multifocal GG2 cancer, treatment is recommended, but we can safely defer it for 6 months and it will not compromise our oncological outcomes. Then is the high-risk disease. The recent retrospective study, including 2,303 men with GG3 or higher clinically localized prostate cancer, there were two groups. One of them had underwent radical prostatectomy in less than 3 months versus those who underwent radical prostatectomy in 3 to 6 months. The results were very obvious. There were no significant difference noted and the 5-year biochemical recurrence-free and metastasis-free survival rate between these two groups. So current evidence for this primary intervention of the prostate cancer, it can be safely deferred for up to 6 months. Then comes the neoadjuvant ADT. ADT prior to radiotherapy for the high-risk prostate cancer is considered standard of care. A review of the National Cancer Database, it suggests that the neoadjuvant hormonal therapy prior to radical prostatectomy, it has increased over recent years. And there are several trials which demonstrate the pathological benefit, for example, reduced rates of the positive surgical margins. And prolonged delay in the surgery, for prolonged delay in the surgery, we can use neoadjuvant ADT as a temporizing measure. Then this table, it summarizes all the discussion we have done so far. Starting from the low disease, this is the conditions. Then is the safe to defer therapy. How we can, what is the time limit, and what up to what extent we can safely defer. And then is the additional concentration and plus strength recommendations, and then the surgical urgency. Starting from the low risk disease. Low risk disease can be delayed indefinitely. Then the active surveillance that can be changed to watchful waiting without biopsy. And there is no surgical urgency. In the intermediate risk, we can safely defer more than 6 months and no change in the management plan. The surgical urgency is low. And in high risk disease, we can defer up to the 6 months, and we can discuss alternatives such as radiotherapy or ADT. However, the strength is weak and surgical urgency is intermediate. For very high risk disease, the safely deferred treatment can be for up to 3 to 6 months, and we can offer neoadjuvant therapy in selected cases. And the surgical urgency in this case is intermediate.
We just stop here and then discuss one by one. I think, sir, the important points till now that have been proposed by this article, they are, for instance, the significance of genitourinary cancers is in terms of tumor biology, since they are heterogeneous in their own ways. So their growths depend upon many different things. They are not one single group. They are actually different organs behaving differently. So that gives a person who is to deal with these sort of patients slightly flexible kind of attitude. We can defer the patient if there is a calamity in our hands. So basically what the article is striving at this point is the present situation in which we are and the situations which might happen in near future. So if there is a point when the healthcare system is not geared up, it needs a little bit of time to collect all the resources. We don't know how much time is at our hand. Now, till now, the whole thinking process and the learning process is we all are inclined towards seeing someone doing something for us in terms of guidelines. So they give us a roadmap. But what these calamities are doing, they want us to rapidly communicating with each other rather than staying for maybe 5 years so that a textbook is changed or a chapter is rewritten or something in terms of guidelines are revised. So that needs a lot of time and earlier we were thinking that it is rather very early to just revise everything every year, but now it seems that every day one has to change. One has to change the way we will be managing or we are managing things maybe last month. So the first thing in this article is to accept the norm. The norm is rapid communication. If somebody is not in the habit of using Twitter, for instance, this is one of the tools, one would be out of the game. The out of the game means that one will not be able to grasp the situation if person happens to be a clinician dealing with the patient. No matter how senior or junior you are, you have to be pragmatic. You have to do something which is actually needed and which is something which is actually has changed. So if you haven't gone through all these discussions in the past 3 months, you are actually at a loss. That is one thing. The second thing for us urologists and for you as medical oncologists is this article gives us a lot of positive sense. At least it gives me a positive sense that if I would have been in the process of these messages, these threads, then I would have been in a better position to guide my patients. It might not be according to the guideline which was published last year, but it might be the collective wisdom or the collective intellect of the whole community right from Brazil to Japan. So this is something which is very important in this article. The second thing, if we come back to organ by organ, what they are saying or suggesting, for prostate cancer we have got 3 things. One is surgery, the other thing is androgen deprivation therapy, and the third thing might be active surveillance and radiotherapy. So where to put all these things so that we can defer our patient to a little bit longer time or a time when this disease is not there in its full capacity or full, in full force. And maybe there is something else in terms of vaccine or drug that can do away with this disease, and then we are again back to the same guideline and the thought process. So what are your impressions about the articles?
Okay. Basically, first of all, these guidelines are written by a surgeon for urologist. And we have to take prostate cancer as a whole as a domain of urologists, radiation oncologists, and medical oncologists. this article was written at the stage where we are now, I think.
Yes, sir.
Getting the peak means at that time the US cases were like 2000, and now we have 2000 deaths. So I think this can make base for us to be, and we can follow the future guidelines because we lag behind. We are ahead in the time zone, but we lag behind. Since Americans are more aggressive in prostate cancer as compared to Europeans, even in high risk and very high risk disease where we usually don't consider surgery, they still wanted to defer surgery with ADT. So this is one basic difference. Even in intermediate risk, 3 plus 4 we consider surgery, but 4 plus 3 we usually say that it's not. Anyhow, you know how this ADT, new adjuvant ADT arise. What happened in Europe, especially in UK, there was a long waiting time for radiation therapy, and patients with prostate cancer, they are elderly and they usually are not happy and they are very much confused that there is a long waiting time. So in order to satisfy them, they started new adjuvant ADT. Just to say that, okay, you are getting a treatment and your radiation will be after a year. Because they have a long waiting time, they have NHS system. And then they did a study and they showed that, oh, this is very good, that has increased the survival and this and that. But for surgery, usually they don't like to have, surgeons don't like to give ADT because they think that ADT will cause fibrosis in the local area and will lead to difficulty in surgery. I don't know what is your experience with that?
The same thing. You see, when our surgeons means our mentors, who are actually telling us how to do prostatectomy laparoscopically, whenever we give them the history that the person is on anti-androgen therapy, they would rather give the same explanation that since the fibrosis would be there, it would be difficult for the planes to be created to exploit and then do radical prostatectomy. But when robotic surgery comes into our perspective, the robotic surgeon tells us that it doesn't matter much for the instruments which are actually used for robotically assisted surgery, because maybe there is something which is known as force multiplier effect of certain instruments. So that is something different for two different kind of surgical platforms. Again, coming back to your point, that if we have got a patient who is a prostate cancer patient, we need to classify the patient according to three categories: the low risk, the intermediate, and the high risk. And we have got three different things to play with because we want a little bit of time rather than going for a definitive therapy. What they think about ADT is it might not be a good option for from oncological side of it, but rather the safety factor for using ADT is very much documented. So you can't just lose a lot. You might not gain many things as compared to radiotherapy and surgery. But when they compare radiotherapy and surgery face to face, they have got another indicator or dimension to the picture of this calamity that is coronavirus. The patient has to come into the hospital many a times. The patient has to be seen by a lot of people, a lot of health workers. All the health workers have to use certain kind of protective gear. So if all those things are put into practice or put into perspective, then for a radiotherapy session which takes like 35 or 36 sessions or visits to the hospital, every time the man hours as well as the exposure time is, I think it's like 36 times for a patient. Diabetes, if you compare radiotherapy with with surgery, the surgery has to be done once, but then there are complications and the patient has to come to the hospital again for the dealing of those complications. So it has to be done head to head according to the resources within which you have to work. So there are many dimensions to the problem. So rather than having three things from oncological benefit type of dimension, you have got other things also to see from the patient's perspective. The patient has to be exposed. Patient has to come out of the room, out of his home to the hospital, and every time the patient has to be exposed. So these are things that have to be taken into consideration. So maybe for all these three different classes, you have got a different kind of recommendation which also takes into account all that I have said.
Yes, sir.
Necessity is the mother of invention. I think without this scenario, nobody will think about delaying surgery or using alternatives. Now we have all these options available which we can use, and maybe in the future for intermediate risk you can put them on ADT and delay the treatment.
Exactly.
That's possible.
Yes. And the second thing is, as we are all here in this hospital, we are all joining heads together to do something for our patients. We have to devise our own strategy. It's not something which is for everyone to just follow. It is something which is an experience of a particular country or particular hospital with a kind of resources that they have. So we have to make our own adjustments within all these recommendations.
And we should make our own guidelines, and we have to implement that guideline. Any new patient who comes with a prostate cancer, localized or loco-regional, we should follow these lines, because at the end of the pandemic or after the end of a certain period, we will know that what was our outcome. Because our patients are probably different than their patients.
And another thing is, it's very easy to say that I'm a doctor, but I'm also a human being, and I need my protection. So I can't just come to the hospital. I can't just see the patient. The patient has to take care of himself. He should not come to you because there is something which is out there in terms of infection. That is the kind of reaction that we have these days for a lot of people, for a lot of other persons within our community of doctors. They don't want to see patients, and whenever a patient with prostate cancer comes to them, or any cancer, for instance, or any disease, we always ask the patient, "आपको तकलीफ तो नहीं थी, आने की जरूरत क्या थी? 3 महीने घर बैठे रहते, मैं भी बचता, आप भी बचते." That should not be the case. But that is because if that is the kind of a statement from the mouth of a person who happens to be a doctor, this is against our oath. Either we should just do away with our oath. We shouldn't take that kind of an oath, or we should put our intellect, our heads together and devise a strategy. There are many solutions to the problem. There is not such thing as just go away, shy away from the problem. आंखें बंद कर लें, तूफान चला जाएगा. ये शुगर मुल्क के साथ हो सकता है हमारे साथ.
Actually, for patient, cancer is cancer. They don't know whether it's a low risk cancer or very high risk cancer.
Yes, sir.
So you have to explain them and the family. This is the scenario. That's why we are doing this, rather than saying it is too high.
A lot of our juniors, they are listening and they are actually thinking that we too are speaking aloud. We too are just glamorous to people who think they are at a higher pedestal. We are not. We are on the same pedestal as you are, but you should speak out of your minds. आप अगर खामोश silent spectators हैं, so that won't solve the problem. Now this is something for you also, but this is something for you more than for us, because you are exposed more than us. You have to use your faculties, you have to use your brains, you have to make certain plans. Otherwise, the times which are coming, this is just one calamity there might be another calamity around the corner, maybe in 2 weeks' time or 1 week's time. And then what would you do? Shut your door and don't come out of your homes. That's not the solution.
At Shaukat Khanam, I am doing my scheduled OPDs, 80-85% scheduled OPDs on either Skype or by telephone. And just telling them that what to do next. If they need medication, somebody can come rather than patient and get the medication. If they need injection like hormonal treatment, usually we give one injection and we give another injection to them to take it at home after 3 months. So you have to do certain extra things in order to reduce the visit of patient to the hospital because they are high-risk patients. Usually prostate cancer patients, these are elderly patients, above 65, 70. So the other option is a telemedicine, which I think so far we are not using, but I think once we are more organized with HIS informative system, then telemedicine will be one thing to reduce the exposure of patients and healthcare workers to the virus.
So moving forward.
Any question, any suggestion?
We'll ask you after this.
Moving forward comes the kidney cancer, and the kidney cancer is divided into two groups, or rather more than two groups. First one is the small renal mass. The small renal mass, in a study at Canada, and they published that was published in 2011. It reported that metastasis was only 1.1% at the median 28 months follow-up. And a recent prospective study which has demonstrated the cancer-specific survival of 100% with AS for small renal mass tumors. So younger patients with a younger or healthier patient, we can defer the intervention for over 6 months and is highly unlikely to compromise the survival outcomes. Then comes the inferior vena cava tumor thrombus. The inferior vena cava tumor is highly risky because without treatment, the median survival for these patients is only 5 months. And 1 year cancer-specific mortality is more than 70%, and which is too large. So the treatment delays, they will pose a potential for the tumor thrombosis, and the tumor thrombus will propagate, and also it heightens the risk of venous thromboembolic events. So we cannot defer these cases, and we have to put them on the list and do them as quickly as possible. Then comes the large renal mass. In these large renal mass, there are different kinetics, and there are different terms which we have to keep in our mind. The most important term is the growth kinetic. Growth kinetic means what is the rate of growth of that tumor. In a study including 68 patients, disease at the stage CT1B, the renal mass, the median size was 4.9, and they found that was followed by 6 months and after that diagnosis, and the median linear growth rate was 0.44 centimeter per year. Some of these patients who underwent delayed intervention, particularly for high linear growth rates, the 0.72 centimeter per year, there were no progression to metastasis, and that was appreciated at the median 32 months follow-up. A separate study that took place and detailing the natural history of untreated CT1B tumors, that found that the lesions which have progressed to metastasis, they had high linear growth of 0.9 centimeter per year compared to 0.67 centimeter per year for the tumor that eventually remained stable. So initial short period of surveillance is required, and at that initial short period of surveillance, we can do repeat imaging or interval imaging at 3 to 6 months. This will have two benefits. First one, we have the surveillance. Second one, we will know the growth rate kinetic and what is the tumor growth kinetics, and then we will decide our plan accordingly. Then the metastatic synchronous renal cancer trial, that is Carmina trial, that was compared the primary cytoreductive nephrectomy followed to the sunitinib treatment alone, and that among the intermediate and poor risk patients. And this study concluded that the sunitinib was non-inferior to the surgery. That means one group was given sunitinib and another group we did cytoreductive nephrectomy. Both have almost the same outcome, and sunitinib was non-inferior to the other group. Then another trial, SORTIME, and that demonstrated that delaying the cytoreductive nephrectomy was a safer strategy, and it allows the early initiation of the systemic therapy and was not having any adverse impact on the disease progression. And on another study, intention to treat analysis, our 28-week progression-free survival was 43% in sunitinib followed by nephrectomy, and other arm 42% in immediate nephrectomy. So there were two groups. One was having immediate nephrectomy and other group was having sunitinib followed by nephrectomy. So sunitinib followed by nephrectomy had 43% progression-free survival at 28 weeks. Then comes the summary of these all kidney cancers. First one is the small renal mass. We can defer for more than 6 months, and surveillance is the excellent tool while waiting for the surgery, and this will also give us opportunity to know the growth kinetics and using existing protocol, and there is low urgency for surgery. Then the repeat imaging in 6 months is required. Then the large renal mass, it is further divided into asymptomatic, IVC tumor thrombus, and metastatic. The asymptomatic cases, we can defer the surgery for 3 to 6 months, and while this period we will do surveillance and establish the growth kinetics, repeat imaging in 3 months, and prioritize if concerning growth rate is more than 0.7 centimeter per year, and the surgical urgency is intermediate. Then the large renal mass having symptomatic, we cannot wait for such a large time because the patient is having pain or bleeding, so we have to proceed within 2 to 4 weeks, and renal or tumor embolization may allow additional time if we can do in such a way, and surgical urgency in these cases are high. And similarly, IVC tumor thrombus, we cannot wait for more than 1 month, and we have to prioritize these surgeries, and surgical urgency is high. Similarly, the metastatic disease, we cannot wait for more than 1 month. We have to initiate some systemic therapy, and however, we can defer cytoreductive nephrectomy, and risk stratification and response to therapy will decide our plan accordingly. Surgical urgency is low.
So, sir, when I was reading this article, I was thinking that for kidney cancer, at least, this kind of plan that has been suggested for these times is actually something which can be used for other times also. For instance, what this article is giving us is, if I'm a doctor and I'm in the clinic and seeing a patient for the very first time, maybe the kidney tumor is in the range of SRM, that is less than 4 centimeter. It might be between 7 centimeter and 4 centimeter, or it is beyond 7 centimeter. So these are the 3 different kinds of groups. Now, if I have got a person who is less than 4 centimeter tumor, then what I'll do the biopsy, because biopsy is done just to give us the definition whether there is something called oncocytoma, benign lesions, and things like that, so that we can just follow these patients. So why we are following? We are actually calculating the kinetics. We are calculating the growth rate. So for all purposes, it is the growth rate by which we have to see. For anything less than 7, less than 4 or less than 7, we can see the growth. If it is growing too fast, if it is growing too slow, depending on other conditions. For instance, if there is no such an emergency as these days, we can do surgery right away, perhaps partial nephrectomy. But for these kind of times, then we can have repeated imaging just to calculate the growth rate. Now, if the growth rate is greater than like 0.9 centimeter per year, obviously we are not seeing it for a whole year. We are seeing it for maybe a couple of months. We can always judge that there is a growth which is on an accelerated scale. Then we can plan our strategy. The fourth thing about is cytoreductive surgery first or sunitinib first. So this article is giving us a clear indication. It is better to start with sunitinib in metastatic setting, followed by cytoreductive surgery. But what we do these days is we do cytoreductive surgery first and then do sunitinib. So if there is a response of sunitinib, then your cytoreductive surgery will always be have an additive factor. So is it correct, my impression?
Before Sartime and what was the second study?
Carmody.
Carmina study. This was the fact. But after these two studies, both are equal. Whether you can give TKI before surgery and delay the surgery, or you can do you do surgery and followed by TKI. Both are equal. It was a non-inferiority trial.
Right.
So our strategy at SIUT is if the patient is symptomatic, have pain or bleeding, then we go for surgery. If the patient has good performance status. If the patient is asymptomatic, relatively asymptomatic, or patient has performance status is not good, then we avoid surgery and we start those patients on SIUT or sunitinib if the patient has symptoms. One thing I was just thinking, I don't know whether this example is right or not. Doing a biopsy and waiting for the surgery is just like doing a mani and waiting for the shadi. Okay, so in that period, you just don't look at the surat. Kitni size बढ़ रहा है. You can look at the sirat also. Sirat क्या है? हाँ? क्या और क्या चीज़ है? सीरत में क्या आएगा? हाँ? कैंसर का ग्रेडिंग और आज के दौर में क्या है सीरत? Molecular. Do we have any molecular marker which can tell us that this patient has a higher growth rate as compared to the other patient? So if we found anything which tells us upfront that okay, if the patient has positive molecular marker which has a predictive value that this patient is going to do bad, you can go for surgery early. So this is an ideal time to do that study, because in US even a low risk small renal masses are emergency for them because it's all insurance system. But for UK, probably their strategy is more relaxed than this because of NHS. So it all depends on the area where we are practicing, and now because of pandemic, they are also geared back a little bit. So I think we can combine with molecular genetics and talk to them if they can do anything on biopsy.
So what's in your mind? Is it
One marker which we use in breast cancer is Ki67. Ki67 is a proliferative marker. It's an immunohistochemical marker, a very simple marker. Still, that is not 100%. We are not 100% sure that this is going to tell us whether patient has a high proliferative tumor index, but a little bit of idea. So there are a lot of markers available. I think we have to search the literature and ask molecular people if they can do these markers over here on biopsy, either fresh sample or a fixed sample, and then make a study.
So it is different from liquid biopsy?
Yes.
It is done in the biopsy specimen.
Biopsy specimen. The only difference is they should tell us whether they need a fresh sample or a formalin fixed sample. So that's only. And this is true for all cancers in which we are delaying our definitive treatment.
Right. So moving forward, then comes
Sorry for the example.
So moving forward, there comes the bladder cancer. Bladder cancer, it has got muscle invasive disease and non-muscle invasive disease. For muscle invasive disease, the standard of care is neoadjuvant chemotherapy, that is platinum based neoadjuvant chemotherapy, and it has got evidence of 5% overall survival benefit and 9% disease free survival benefit. However, on the other hand, if we look for the COVID-19, the case fatality rate that could increase by 3 to 12 fold in the patient receiving the chemotherapy. So we have to weigh the benefit versus the risk. If we treat with this neoadjuvant chemotherapy, then we will have only 5% benefit. On the other side, we will increase the risk of COVID-19 to our patients. Another thing that is, and we should keep in our mind, is the combination of radiotherapy and chemotherapy that has been used quite successfully in European centers and is less likely immunosuppressive as compared to the this neoadjuvant chemotherapy, and it can be considered as alternative if cystectomy is not desired or is not possible. Another study of the patient undergoing upfront radical nephrectomy and those with a surgical delay. Those with a delay of 60 to 90 days between the diagnosis and surgery versus another group in which the delay was not that much. The transurethral resection to surgery, there was a significant difference, approximately double as compared to that. For instance, in this case, where a delay of 60 to 90 days, there was 34% increased risk of death as compared to the second group, which was not that much delayed, and it has got only 18% increased risk of death. Then comes the non-muscle invasive disease. In the absence of symptoms, TURBT, that can be delayed, and we don't need urgency to resect the papillary or small tumors. And secondly, there is an immediate surgical priority for those with the persistence or recurrence of high-grade T1 disease after BCG therapy. Another thing to keep in our mind is the high grade with CIS. This is also having urgency because it has got adverse clinical trajectory and it should be prioritized for the radical cystectomy, otherwise the outcome will be worse. And several studies on the bladder preservation with the salvage intravesical chemotherapy, for example, valrhexavirine and gemcitabine, and they don't necessarily compromise the outcome, and they can be used to immediate radical cystectomy followed by BCG. For example, we can use these intravesical chemotherapy and they have significantly comparable outcomes than the radical cystectomy. So this is the bladder tumor cancer, and this has summarized whole scenario. It is a bit busy slide, but we will go bit by bit. Starting from the newly diagnosed mass TURBT, the papillary or asymptomatic and solid asymptomatic, we can defer for 1 to 2 months. And deferred resection, that has got some risk. For example, in the resection we had got hematuria, clot retention, patient has to come to ER or admit, and there is increased resource utilization, so we can defer these cases, and the surgical urgency is intermediate. Then comes the symptomatic, having hematuria and pain, we cannot defer these cases, we have to proceed within days, and there are no alternatives as well, so this has got high surgical urgency. Then the non-muscle invasive bladder cancer, then that has got one option, radical cystectomy. Radical cystectomy is preferable for those cases having BCG refractory that has got T1 high grade, and it can also be for asymptomatic. We can defer for 2 to 3 months. Longer delays will worsen the pathology and survival, and alternative for intravesical agents can be tried. However, the strength is low and there is no low surgical urgency. Another thing is that even with high grade plus CIS and symptomatic patients, we have to proceed within 1 to 2 months, and longer delays will worse the pathology and survival. And intermediate surgical urgency is in this scenario. Then the muscle invasive radical cystectomy is the plan, and we can defer for 2 months. And the neck neoadjuvant chemotherapy with deferred surgery can be offered. And second stage CT2 primary radiotherapy may be used if surgery is not desired. Then the cisplatin ineligible and the increased risk of COVID-19, age, fertility, and decreased immunity. These patients have the facility should be isolated to mitigate the risk of COVID-19 due to frequent visit. So if we have got some protective measures, we can proceed with the neoadjuvant chemotherapy. Otherwise, we have to do further surgery. Surgical urgency is intermediate. Then the stage CT3, the delay can be deferred for 1 to 2 months, and neoadjuvant chemotherapy with deferred surgery if resources are available to mitigate with COVID-19. And cisplatin ineligible. Otherwise, we can proceed with the surgery, and for the after neck or any stage, if still it has got high stage, then we can defer for 1 to 2 months, but don't go further, because further delay will compromise the survival outcome. And both these cases have got high surgical urgency.
For T1 high grade plus CIS, in your previous slide, you said that surgery is the only option. I think one of the option is BCG also. So I don't know why they did not. Can you go back to your T1 high grade plus CIS? High grade T1 disease with CIS have adverse clinical trials and should be prioritized to radical surgery.
Right, from the North American perspective, I think this was the statement which they propagate. Maybe there is a guideline.
So actually it is coming after this slide, and that is saying that high grade is that which has BCG refractory. So yes, sir.
For all practical purposes, I think it gives us a clear picture, clearer than the other things also. And the clear picture is anything which is muscle invasive or anything which is like high-grade T1 or with CIS, cystectomy is the choice. But the standard of care is, I think, neoadjuvant chemotherapy followed by cystectomy.
For muscle invasive.
For muscle invasive. But the problem with, again, both the things are the same. For instance, if you do cystectomy, this is something which is in urological setting the most complicated kind of procedure. Complicated means that it is not only a lengthy procedure because it combines two things. One is ablative, the other one is reconstructive. The second point is there is a 30% readmission rate with cystectomy. There are many problems with wound. There are many problems with other things. So if you calculate repeated admissions and exposures to the patient with chemotherapy, which is like 3 to 4 weeks, and the person has to come to the hospital, plus there are complications and readmissions with chemotherapy also. So both the things can balance on time scale. Otherwise, it gives you a clearer picture of how to proceed. You can't just say that, okay, if there is no problem, I can defer my patient for maybe 6 months. That you can't do. You have to put yourself maybe in a compromise or squeezed form of timeline, but then you have to decide which way to go. For a papillary cancer, which is non-muscle invasive, you can defer it for maybe two months, but not for anything else. You have to do something. And one point which was missing in kidney was thrombus. If there is a thrombus in renal vein, if there is a thrombus in IVC, you can't just put away that patient for months. You have only 1 or 2 weeks to decide, and you have to do it. Otherwise,
In this list, we don't have a strategy to do check cystoscopies because usually we do check cystoscopy every 3 months initially. So, do you think that we can delay that to 6 months rather than 3 months?
Yes, sir, that can be done. That can be done. And that can also be replaced by, for instance, if you don't want to do check cystoscopy, if there is nothing on an ultrasound, you can have a urine sample for cytology. So that gives you not the clear picture, but maybe a picture which is representative.
Exactly.
So,
Do you think office cystoscopy is a relatively safer procedure as compared to in OR doing anesthesia and do?
just anesthesia is not involved, otherwise everything is the same. I mean, we have to protect ourselves, we have to protect the patient. Anesthetist is not there, so the anesthesia machine and anesthetist, these two things are missing, otherwise procedure is the same. So, आज कितना time?
दो कैंसर
हाँ?
दो कैंसर है
Short.
अपर ट्रैक है और टेस्टिकुलर है
Right.
थैंक यू